So as Ali said, it's fantastic to be here at the third meeting after our first kickoff. So we're 4 years into it, and I thought it'd be nice to sort of just summarize where we are in terms of therapy development, and I think for all our initial thoughts and around what mission we had and what steps we were going to take to come where we are, things have evolved quickly and slightly differently than we thought, and I think it's worth it to reflect on this, because as we look forward to the next 5 years, let us be aware that we should be in tune with what is happening in the landscape overall. So I was asked by Ron Bartek and Marty Fraser, so here, coming from other disease groups, they were quizzing me, who is the audience here? And I was trying to explain that, we're sort of a third physician scientists, a third patient advocates, but also a third industry. And more I was thinking about it, more the boundaries started to blur, because I actually feel a lot of us are coming here as patient experts who've really given us sound scientific advice over time, and some of our industry partners are true academics, and so I think the nice thing is that we have a community that's quite dynamic and really able to take on different perspectives, and that's part of the opportunity and challenge here. What I'm going to try and do first is speak to these 4 points that have hopefully set the stage for describing where I think we are, and this is all up for debate. I will first describe the phenotypes of adrenoleukodystrophy for those particularly who are not familiar with our disease or who are becoming new to this disorder, then go into the therapeutic landscape of ALD, describe challenges and needs in advancing treatments, and hopefully then end on an upbeat note about progress in biomarkers and outcome measures. So for those of you who are new to ALD and adrenoleukodystrophy, let me just briefly describe this as a single gene disorder that affects the peroxisomal half-transporter called ALD protein, sits within this organelle in the cell, and is important for importing very long-chain fatty acids into this organelle. Why does this have to occur? This import of very long-chain fatty acids into this organelle allows for the degradation of these very long-chain fatty acids. So it acts a little bit like a trash can and allows for that degradation. We know that there have been more than 1,000 mutations detected, more than 700 of them unique, and a wonderful database that Stefan Kemp curates. But there's been no genotype-phenotype correlation to date, which means that you cannot simply by knowing your mutation predict what clinical course you will have. Okay, so full screen.
I got it.
And similarly, very long-chain fatty acids, while they are diagnostic and while they have now led to us having newborn screening, the level of those very long-chain fatty acids do not predict what course you will have, whether your brain will be affected or your spinal cord, and with what rate. What we do know is that there are 2 distinct neurological phenotypes: the acute brain inflammatory demyelination, called cerebral ALD, and the axonal degeneration of the spinal cord, called AMN. Important to remember that even they're still outside of the nervous system, other organs are affected, such as the adrenal gland, and it's important to monitor for adrenal insufficiency and make sure that patients are protected during infections. So we will focus on the 2 main neurological phenotypes known as AMN, adrenal myeloneuropathy, the most common phenotype. We have more than 3,000 patients in the US, and we still have no effective treatments. This is a disorder affecting the spinal cord, and we do have a mouse model of this disease. By contrast, cerebral ALD, the most severe phenotype, inflammatory disease of the brain, where we do not have any mouse model, but interestingly, we do have first effective treatments in the early stages. So how do we think about these two phenotypes over the course of a lifetime? You were born with ALD, you have elevations in very long-chain fatty acids, you you carry a mutation in ABCD1, and then you are at risk for developing cerebral ALD in about 30 to 40% of patients between ages 5 and 10. If that doesn't happen, you go on into adulthood, and the main risk you remain at is a spinal cord degeneration called AMN. You still have some risk of developing cerebral ALD. So you can see in adulthood that these two phenotypes intersect and overlap. Very different in the pathology. On the one hand, cerebral ALD affecting the brain, confluent lesion that spreads outward like wildfire, bears these areas right underneath the cortex, and has massive infiltration of inflammatory cells, monocytes, lymphocytes. By contrast, no infiltration of lymphocytes and intact blood-brain barrier in the spinal cord of AMN. This is a degeneration of two areas: the back of the spinal cord, called the dorsal column, where all the sensory information comes through, and then the side of the spinal cord, called the cortical spinal tract, that regulates motor activity. Okay, we can use MRI to track cerebral ALD, and this has really transformed the field and led to first trials for the boys. Much harder for AMN, and I'll talk a little bit about that, but you can see lesions within the cortical spinal tract. Okay, so this is the landscape of ALD as I would like to present it today. And I've done this in a way in this talk so that it's really something that not just physician scientists, but also patients and also industry can look at and try to think with us together where we are. So as I said before, you are born with the gene defect, and then you are at risk for these different phenotypes. And these an MRI mainly helps us in defining the different stages of these phenotypes. So between 4 and 9, you can even in a pre-symptomatic child perform an MRI and see a lesion emerging while there are no symptoms at all. And then once contrast enhancement sets in and the real inflammatory part of the disease starts, that's when the acute symptomatic stage starts, and many symptoms and functions are lost. In adulthood, AMN doesn't affect the brain, although you can see some of the long tracts on MRI. But you also remain here at risk for developing cerebral ALD. What I want to point out is that right now, we are really only treating this one sliver of this disease, okay? So this is worth pausing on, okay? That we actually have proof of concept that we can treat this single gene disorder, but we can only do that in the early stages when contrast has just arisen, but it is not yet gone too far, and we feel things are still reversible. What would happen if we could start expanding this to include a treatment of not advanced cerebral ALD, AMN, adult cerebral ALD, and maybe even the earlier phases of cerebral ALD? And I think that's part of the goal and the concrete objective of what we're trying to achieve as we're thinking about this landscape. So I would argue that as we understand the landscape, the treatment targets in ALD and AMN are expanding. We now know of gene therapy approaches, lipid-lowering strategies, immunomodulation, antioxidants. And I think important for us to really take on assessing symptomatic treatments. I'll go over these briefly. So in terms of gene therapy, not to go into this in depth, but many of you have followed the first report of a trial of ex vivo gene therapy in boys with cerebral ALD. This really talks about this early cerebral stage that we've found amenable to treatment. But we also know that there are approaches using other viral vectors that allow for direct delivery, and these are used
these are in preparation for direct intrathecal delivery into spinal cord. There are multiple trials around the world for other diseases using also stereotactic, meaning direct brain injection, or intravenous administration. What I want to convince you of is that the phenotypes that I talked about, spinal cord versus brain disease, will determine optimal timing, modality, and delivery. So lipid-lowering strategies is something that's been in the field for a very long time. Our mentor, Ali, and I had Kenny Krieger, Hugo Moser, certainly shaped this field by an understanding of very long-chain fatty acids and also an understanding of how to manipulate very long-chain fatty acids and lower them into normal range. What he found is, yes, this could be done in plasma. This could be done in the pre-symptomatic stage. Once cerebral ALD occurred and the inflammatory phase was underway, lowering very long-chain fatty acids was not helpful. And there's still an ongoing debate whether lowering them in the pre-symptomatic stage reduces risk for conversion to cerebral ALD. I think we are now seeing many newer lipid-lowering strategies emerge that might be more effective. We have here who has done a lot of work on ELOVL1 inhibition. This is the enzyme that synthesizes very long-chain fatty acids, and we're hoping that drugs that target this pathway in the near future will lead to trials that show lipid-lowering potential as well as impacting outcome. ABCD2 upregulation, there are several trials underway, work from Johannes Berger originally and then Thomas Scanlon, leading to new compounds like thyromimetics that are able to look at genes that can compensate for the function of ABCD1, the closest being ABCD2. There are several other novel strategies to combat inflammation, oxidative stress. Sunata Kannan at Johns Hopkins working with Ali Fatemi and developing dendrimers to transport antioxidants into the brain, seeing whether the innate immune system may be amenable to this treatment. Aurore Pujol has spent many years and decades trying to understand oxidative stress in mice and in humans, showing that oxidative stress occurs very early in the mice, around 3.5 months of age, one of the first manifestations. So very important insights that are leading to new drug targets. I would argue that beyond that, we should be looking at also symptomatic treatments that patients are already undergoing for their symptoms, whether it's for bladder dysfunction, bowel dysfunction. How do we know what works? And a lot of patients come to me and are reporting that they are on different medication at different stages of their disease. Things are more or less helpful. And I think as a consortium, we should be spending more time on understanding how effective existing symptomatic treatments are in this realm. So how to now translate these preclinical studies to trials in humans? I think we all agree that there's a lot of preclinical work that's happened and that there are wonderful insights at the bench, but how is this helping patients? How is this actually moving forward? Can we understand the gaps in the treatment pipeline? Can we look for synergies across phenotypes and treatments? And can we learn from other related disorders? So it's very important to us that we actually bring in other disorders into this realm. And can we advance model systems in ALD and AMN? So one way I like to look at this, at the pipeline for treatment, is to say, yes, we have for every pathway or every part of the biology, there are strengths and weaknesses. Maybe sometimes we have a new wonderful model system, but there's a missing biomarker, or there's no industry partner to advance a certain treatment that's working well in mouse and early human studies. I think across all of these different pathways that you might be investigating in a disease, the patient perspective is central. We need to understand what's meaningful, whether what we are impacting makes a meaningful difference to patients. But often we get hooked in one piece, in one part of this whole pipeline. and we need to address the gaps. And I'll speak a little bit to that. So if this is the phenotypic landscape of ALD, and we know that certain things work in one stage of the disease, or we know we have a diagnostic biomarker, I would argue that we should really start looking for a shared pathophysiology across different diseases. For a long time, we thought there's no inflammatory component to AMN. Now we're starting to realize that maybe there's an innate inflammatory component to AMN, although it's not adaptive, so there's no lymphocytes infiltrating. Are there common biomarkers or outcome measures of interest? I would think that actually across all the different stages I described, there are some shared perspectives where there could be exchange and a way to galvanize the field and help even patients who are advanced cerebral ALD who are saying, okay, I may not be a candidate for bone marrow transplant, but are there still antioxidants? Are there still other treatments that could help me? And what kinds of biomarkers can we use to track that? These might be coming from other fields. So we want to learn from other more common neurologic diseases. There's been a lot of work trying to pull the knowledge from multiple sclerosis, inflammatory demyelination together. ALS, we've learned a lot from the group of Northeast ALS Consortium, and Friedreich's ataxia certainly has some common pathogenesis with AMN. Each one of these diseases has a different pathophysiology that is reflected to some degree across the landscape of ALD. So inflammatory demyelination, clearly seen in cerebral ALD, degeneration of upper and lower motor neuron, degeneration of the spinal cord relevant to AMN. And of course, we're looking to these diseases to see how successful were they in getting drugs approved. MS certainly has gotten several drugs approved based on 25-foot walk tests, et cetera. And ALS, there's recently been one more drug approved by the FDA. To my knowledge, I don't think there are any drugs approved for Friedreich's ataxia yet. But I think watching the process and how regulatory feedback is informing each of these other diseases is vital to us. I was at an ALS meeting and looking at this particular slide on gene discovery. And if you look at ALS that gets so much attention, it is really a conglomerate of multiple rare diseases, okay? So SOD1 was the first gene that was discovered, and then many others, and C9orf thereafter. And it occurred to me that really the way we think of ALD and AMN really just depends on vantage point. So what if we said ALD or AMN is actually hereditary spastic paraplegia, and we said ABCD1 is one among many genetic causes of hereditary spastic paraplegia. All of a sudden, we're in a different landscape. We're in a different place, and we can draw upon many other insights that are occurring across different diseases. So I want to make a plea here that we should open up the field a little bit to not just think about one gene, one biochemical abnormality, but say, if our phenotype resembles something else, what's happening in that other field? What could be learned from other HSP and hereditary spastic paraplegia genes? And so I just looked at some, put in some slides here briefly about the world of hereditary sensory neuropathies and hereditary spastic paraplegias, both of them relevant to AMN. So if you look at hereditary sensory neuropathies, there are several dozen genes that are known to impact different functions of the cell, everything from the cell body down to the axon and the innervation and the small fiber neuropathy that occurs. And we've actually just completed a trial in another hereditary sensory neuropathy that's been positive. And I keep scratching my head whether there are insights that can be gained that would help AMN. Similarly, for the hereditary spastic paraplegia, so the motor component of that affects the spinal cord, here there are multiple genes that affect trafficking across the axon, where new insights could be used for AMN. And why is that? Well, the corticospinal tract and dorsal column in AMN are affected the longest tracts in the nervous system. And but beyond us knowing that this neuron and its projections are affected, we also have to acknowledge that different from many other hereditary spastic paraplegias, AMN is a non-cell autonomous process where the gene and protein is expressed in the glial cells surrounding these long axons. So this pathophysiology is key, and it's key because we need to know where to look to get other new insights. Speaking of new insights and developing new model systems, I think another shout out here for the need for new model systems to study ALD and perform drug screening. And here I want to applaud Josh Bonkowski, who's developed a new animal model system in zebrafish in order to allow for drug screening for ALD and AMN. And I would say we need further model systems to study ALD across all neurodegenerative diseases. There is an impetus really to think about what insights can be gained from different model systems. And clearly there's a need to scale up from the mouse that doesn't resemble the human. Okay, I'm going to close here with progress in biomarkers and outcome measures. I want to show you a little bit about how we think about outcome measures and biomarkers that will inform trials, both for cerebral ALD and AMN. And lastly, but importantly, patient priorities and reported outcomes and how we think about this. So I think the first step, and others who are physician scientists in the field hopefully agree, was Jerry Raymond putting together a score, a scale called the Neurological Function Score that helped us capture the various different functions and domains that are affected in childhood cerebral ALD. And this was massively important, as much as many of us complained that it was still very it didn't allow for the granularity and the small changes that we're assessing, but it had a gestalt to it that really captured what was happening in cerebral ALD. And this helped people say, okay, along these 25 points that you can gather as your disease gets worse, what can we change? What can we impact? And where are the major functional disabilities that could be altered? And this really helped with trial design. So if you want to know what you want to change, it is much easier to start a treatment. And this is exactly what we did when we started with the STARBEAM study, where we were able to compare to the untreated natural history and say, okay, clearly in the, as we treated patients 1-2 years out from the ex vivo gene therapy, the large majority of them were surviving with very good function, not just surviving, but having good function. And I think that's important because in the past, a lot of the bone marrow transplantations that we were assessing, we were looking at survival alone. And that fact that we were just looking at survival didn't give us enough information. We needed to know what kind of function, what kind of language, motor, and other functions are retained and what quality of life is given. So as I mentioned before, MRI helps track how the lesion progresses, and you can see something that starts in the corpus callosum, spreads out into the subcortical U fibers, and moves into the frontal areas. This can be quantified, and Dan Less, a radiologist in Minnesota, helped develop a scale, 0 to 34, and using the scale was able to say, okay, we can track progression over time. We can track progression even in the pre-symptomatic stage when we do not see symptoms yet. And if we can actually stop that disease right at that phase, wouldn't that be wonderful? And more importantly, we understand that there is a hallmark of the disease, the contrast enhancement that occurs around the lesion and that in the active stage of the disease. Can we stop that inflammation? Can we stop this disruption of the blood-brain barrier? Wouldn't that be a way to know whether some drugs are effective in the early phases? And clearly this MRI scoring system helped us in our first gene therapy trial, where we found that about half of the patients stopped with their lesion progression immediately, and the other half stabilized about a year after treatment. Challenges remain. We understand that we can reduce the disruption of the blood-brain barrier, the contrast enhancement that we see in this disease, but in some cases, that contrast enhancement emerges again. It never emerges to the same degree after we treat with ex vivo gene therapy, but we see it happen again, and it keeps us on our toes and worried whether we are truly putting out the fire here. And so we've spent a lot of time thinking about the blood-brain barrier, and we now understand that ABCD1, this defective gene I started off telling you about, disrupts the blood-brain barrier because it doesn't allow for these tight junctions to occur between the endothelial cells that are the boundaries of the blood vessels in the brain. And because these tight junctions are disrupted, inflammatory cells can now migrate through this blood-brain barrier, and contrast enhancement occurs. Patricia Mussolino has used some advanced imaging at MGH to characterize this blood-brain barrier even further, and she's found that actually long before you see contrast enhancement occur, there are already changes in capillary blood flow, both in heterogeneity of blood flow as well as in the leakage and measures of permeability, and this heterogeneity of blood flow can be found altered about 6 months to a year before you see contrast enhancement. So let's now switch to AMN. Importantly, and I said more than 3,000 patients in the US, the most common phenotype in dire need for treatments. We really need to get this trial design right. So what does this look like, and what can we quantify about this disease? Maybe, Dean, you can click on this if it works. Otherwise, I'll describe. So clearly a disorder that affects gait, that is a lifelong disability, sensory disturbance in the legs, causes balance problems, but many things that are not seen that patients report about are urinary hesitancy, bowel problems. I often will hear from patients, well, people look at me, they see a cane, they see a wheelchair. What they do not see is that I can't leave the house because I have bladder problems, because I have bowel problems. You know, if I have modalities to help myself for my gait, for my balance, I do not have those for bowel and bladder. So this is the thing I think that is really important for us to stress and to bring to the attention also of regulatory folks who can help get us drugs approved based on these measures. Important that AMN does not only affect men, it also affects women. Wonderful work by Mark Engelen in Amsterdam has really highlighted this, that women also develop AMN-like symptoms later than men, but they do. You see both spinal cord, peripheral nerve affected, and it causes gait problems, balance problems, but different from men. There's more fecal incontinence, leg pain, and sensory ataxia in women compared to men. So very important insights here. How can we measure this? How can we quantify these kinds of changes in function? Work by Kazi Sokovsky at Kennedy Krieger has emphasized strength, balance, sensation, using the various tools from force plates to dynamometer to help quantify this. And this has helped us understand different stages of the disease, that there are mild, moderate, and severe the affected AMN patients. And the challenge now ahead of us is to say, can we describe rate of progression, and can we understand whether they're fast progressors, where if we measure the intervention of a drug, that we can in a short time know whether something is working. I mentioned urinary and bowel symptoms before. Here we did a retrospective study in 67 adult patients at MGH, and we found that urinary symptoms were reported in 64% of men, 68% of women, and bowel symptoms 44% of men, 64% of women. So clearly something that is very prominent and in need of further definition. Spinal cord and imaging is probably going to be the modality that is the counterpart to brain imaging for cerebral ALD. We know through a lot of nice work at Kennedy Krieger that there's spectroscopic changes, magnetization transfer is sensitive to myelination, and these imaging modalities correlate with clinical symptoms. Just to highlight what Ali Fatemi has done over the years, where he's been able to show that magnetization transfer shows changes in exactly those regions I described before, dorsal columns and cortical spinal tracts. Well, isn't it nice to have a tool that can actually describe the areas where pathology is occurring? And I think these are the things we should be exploiting. Letterio Politi in Italy who recently moved to Boston has shown that the spinal cord is also smaller in AMN compared to controls. Well, again, this is such a hard measure. This is something that we should be able to take and say, if we understand this is changing, if we understand the risk that is occurring here, we should be able to use that in order to assess whether drugs make a difference. So lastly, the patient portal for ALD and AMN. Who knows most about adrenoleukodystrophy? It's not the physician scientist, it's the patient who lives with the disease, okay? And we acknowledge that, and we need help in order to make these measures and this quantitation also meaningful. And so we've, through this patient portal, encouraged patients to sign up. We've had 475 accounts created, 344 patients registered. We have various different forms in there that where patients report on their priorities, on what kinds of resources, what kinds of research they would like to see, and they can also use a tool called NeuroTracker to track their own daily function. Shout out here to the team at NeuroBANK, Alex Sherman, Amanda Nichols, who've further helped also create physician-enter data in NeuroBANK, and across 5 different centers, we have started entering phenotypic information. What we are now really trying to do is, beyond the phenotype, define what are the measures that will be most sensitive to change that will inform a trial. And this is what we really need the drug developers' input on, so that we know what you are targeting, so that we can put those specific outcome measures into NeuroBank and correlate them not with patient-reported outcome. And I think that's one of the beauties of the system, that crossover is possible. We're beginning now to compare physician and patient-reported outcome where patients have both gone into the portal as well as gone to a physician at one of our sites, and physician-entered data exists. So now we can compare these 2 different perspectives, and this is exactly what FDA is looking for. Rachel Saltzman has really taken this a step further and worked together with Jacob Keene at the University of Utah to start now envisioning what methodology would be needed to further conceptualize the meaningful aspect of patient-reported outcome. What they're going to be doing is a 2-step approach. On the one hand, do qualitative interviews to assess what items matter most to patients, and then look at whether these items are truly already captured by some of our performance measures, and if not, look at new items that we should understand thresholds of meaningfulness around. So I would be amiss not to mention the great progress a lot of our patient advocates and Lisa Seeger, Amber Saltzman, many others here, Gene Kelly, of course, to bring about newborn screening, a milestone in this disease, something that really is changing this landscape, and something now rolling out state after state. But it is also now raising the question, how can we engage early? How can we really get to these patients and not just diagnose them, but sustain involvement, sustain engagement? And I think that's going to be the hardest thing, because there's nothing sadder than knowing the diagnosis is there and then the monitoring wasn't in place to make a difference in that patient's life. So where are we today? Just briefly to summarize, I think we have disparate, distinct phenotypes that remain challenging. Why it is sometimes hard to translate certain approaches from other diseases is because our disease incorporates different kinds of phenotypes, some of which are more spinal cord, some of which are more cerebral ALD, and understanding how to navigate that landscape remains a challenge. Nevertheless, we need to leverage synergies due to this gene defect and close the gaps across the therapeutic landscape. Innovation, new biology, and treatment is happening. I want people to see that there is progress, but we need to expand it further. New outcome measures can really change the field. And I think this is both for the technology side, where imaging has been a boon, but also in terms of really using new tracking devices, understanding mobility, what can we do real-time tracking-wise. And patient perspective is crucial to define meaningful. We need that, and we need your input in order to do that. Okay. So sorry it was a little long, but this will hopefully set the stage. Thank you.